Good morning. This class is for NUR 668, Adult Gerontology Acute Care 2. The purpose of this class is to review mechanical ventilatory support and different modes. But before we begin, we'll review pulmonary physiology as well as oxygen delivery. Let's go over lung compliance first. Lung compliance is basically a measure of how easy it is to inflate the lung. When you inflate something, compliance is high. Basically, lung compliance is higher at the base of the lung and is lower at the apex of the lung, as well as ventilation. This means that inspiring a tidal volume of air causes more expansion at the base of the lung, and that the lung units at the base is more susceptible for collapse. If it's hard to inflate something, compliance is low. For example, patients with pulmonary fibrosis is very difficult to inflate the parenchyma during inspiration. Therefore, for those type of population, compliance is low. The same thing happened with patients with ARDS. Compliance in the lung is basically defined as a change in volume divided by a change in pressure. A typical normal lung compliance is 200 ml centimeters of water. Compliance is divided by the initial volume of the lung. It's the property of the lung tissue itself and is not dependent by body size. So therefore, there's no difference in lung compliance when patients are morbid obese or when patients are have a normal BMI. Compliance basically depends more on how much tissue is being considered. Patients with, for example, asthma, they have they don't have the same lung compliance as patients with emphysema, because remember, emphysema with the septal rupture, they have less lung tissue to expand. So therefore, for them, the lung compliance is low as compared to asthmatic patients, for example. Compliance also is inverse proportional to elastic recoil. Elastic recoil basically is the inherent resistance of the tissue to change in shape. It's the tendency of the tissue to revert to its original shape once it was deformed by inspiration. So it's basically the coefficient of retraction is the effective pressure of maximal expiratory airflow, which is very much increased on patients with severe emphysema. In other words, if compliance is low, such as in patients with emphysema or patients with pulmonary fibrosis or ARDS, the elastic recoil is high because they are inverse proportional. This means that the lungs are stiffer and there is a greater tendency to lung collapse. And I already provide you examples of it. So again, is a term used to describe resistance in relation to elasticity. Examples of low compliance: when the lungs are stiffer, such as pulmonary fibrosis, ARDS. Pneumonia is not only the acute pneumonia, it's this acute pneumonia that is associated with interstitial edema. And is not a regular atelectasis by bacillar when the patients leave OR, is the lung collapse from a mucus plug. So that's the atelectasis that I'm referring to. Patients with high compliance, they're more distensible. So this is the normal population. Let's talk a little bit about the interchange of gases between an organism and the environment. Basically, respiration is done by three processes. This is done by ventilation, diffusion, and transport. Physiological respiration is basically the flow and the transport of metabolites between an organism and its external environment. Simple diffusion is sufficient for gas exchange, since every cell is bathed in its external environment with only a short distance of gases to flow across. Humans have a much greater distance between the environment and their innermost cell, that's the respiratory system, and is needed for effective gas exchange. Respiration is the transport of oxygen from the outside air to the cell within tissues, and the transport of carbon dioxide in the opposite direction. The respiratory system works in concert with the circulatory system to carry gases to and from the tissue. So basically, ventilation is moving of the environmental air into and out of the alveoli of the lungs. So again, in other words, is the movement of air between the body and the environment, and the distribution of air within the tracheobronchial tree to the alveoli. And that is affected by the respiratory pressures, the intrathoracic pressure, which is negative, surface tension, which is basically regulated by surfactant, and lung compliance that we already discussed. Pulmonary gas exchange is the exchange of gases between the alveoli and the pulmonary capillaries. The gas exchange passes between the peripheral tissue capillaries and tissues of and other organs. So basically, it's the gas exchange across the alveolar capillary membrane into the pulmonary blood supply. Remember that CO2 is 20 times more diffusible than oxygen across the alveolar capillary membrane, and that is affected by other 5 variables, which are surface area, membrane thickness, amount of hemoglobin, partial pressure, and diffusion coefficient. The gas transport is basically the movement of gases within the pulmonary capillaries through the circulation to the peripheral capillaries in other organs, followed by a movement of gases back into the lung along the same circulatory route. We already discussed the ventilation perfusion mismatch in class, but remember that normal ventilation and perfusion is when ventilation equals perfusion. There's no any level of disturbance in the pulmonary parenchyma or the capillary. When you have a shunt, remember you could have either low ventilation or zero ventilation, which is basically a silent unit. And that is examples of those are any type of pulmonary disturbance or illness, from pneumonia, pulmonary edema, atelectasis, COPD, chronic bronchitis, emphysema, anything that affects the lung. In contrary, alveolar dead space is basically when ventilation is normal, but perfusion is compromised, and this is the best example is a pulmonary embolism. Remember that there are many disease processes that could be in either situation, but we have to be able to separate them and differentiate them to in order to be able to answer questions. But in clinical practice, there's an interchange of these concepts. Total lung ventilation is no more than the sum of the dead space ventilation plus the alveolar ventilation. What is dead space? Is the volume of inspired air that does not participate in gas exchange. When we talk about dead space ventilation on a patient that is mechanically ventilated, this is not the same dead space with a VQ mismatch. I'm just talking now, what is dead space when the patient is in mechanical ventilation? Is basically your upper airway. You have, for example, an ET tube connected from the mouth to the trachea and into the bronchoalveolar space and into the alveoli. Well, your upper airway, meaning normally you breathe through the nose. So that nose is, and sinuses do not participate in ventilation for this patient. The trachea, even though the ET tube is inside the trachea itself does not participate in ventilation. So therefore, this is wasted ventilation. And the ET tubing itself. And the narrower the size of the tube, or the smaller the tube size, the higher the dead space. Ventilation and gas transport requires energy to power the heart as a pump and the muscles of respiration. Remember that the diaphragm participates in ventilation as well as the intercostal muscles. In heavy breathing, energy is also required to power additional respiratory muscles such as the intercostals and the escalene and the sternocleidomastoid. While ventilation and gas transport directly require an energy input, the passive diffusion of oxygen and carbon dioxide into and out of the cell does not require energy. Key points to remember is that respiratory system works in concert with the circulatory system to carry gases to and in tissue. Ventilation and gas transport requires energy. And remember, your intercostal muscles and diaphragm also participate. Movement of gases within the pulmonary capillaries through the circulation and into the peripheral capillaries to the organs is followed by movement of gas exchange and thus passive diffusion. Alveolar ventilation is basically the portion of total ventilation that takes place in the alveoli for gas exchange. And the best indicator for that is the PaCO2, is the partial pressure of CO2 at the level of the alveolar. When the patients have a normal ventilation, there's an adequate PaCO2, so the PaCO2 remains within 35 to 45. When the patient is hypoventilating, such as all the examples that we discussed in class, patients that are opioid overdose, patients that have kyphoscoliosis or any type of deformity of the chest wall, patients that have central nervous system problems, patients that are retainers of CO2, then the PaCO2 will be high. And on the contrary, patients that are hyperventilating in anxiety or any type of shunting problem, the PaCO2 is expected to be low, because they're hyperventilating. What is ventilatory failure? Well, basically, it's the clinical state produced by PaCO2 when it rises quickly enough to produce an immediate life-threatening situation. And you could obtain different numbers when you read different sources. Remember that ventilatory failure or respiratory failure is no more than when the PaCO2 is greater than 46 or 50. Signs and symptoms of hypoxia, you already know them, but let's review them. It's tachycardia, patient is tachypnic, they're dyspneic, shortness of breath. They could also have euphoria, anxiety, tachyarrhythmias, But if the process continues, these tachyarrhythmias could convert into bradycardia. Patients tend to come in initially with hyperventilation, therefore the PaCO2 is decreased as well as the PaO2. Patients could have elevated blood pressure, they could have altered mental status, up to coma and death. Clinical conditions that could increase the risk of hypoxia from pulmonary problems, and since the pulmonary system is connected to the circulatory, patients could have myocardial infarction from the ischemic process. Sepsis could produce hypoxia, drug overdose, liver failure, CNS disorders, CHF, hypovolemic shock as well due to ischemia, blunt chest trauma, acute neuromuscular diseases, acute abdomen. Don't forget the abdomen. Patients that have any type of abdominal disorders, including cholecystitis, pancreatitis, duodenitis, diverticulitis, bowel obstruction, any perforated bowel, mesenteric ischemia, anything related to the abdomen could paralyze the diaphragm, and that could impede the ventilatory support. Patients with acute pancreatitis as well as a spinal cord injury. Indications for oxygen therapy. Of course, the most likely and the most common is patients with hypoxemia, but patients that are tachypnic for unknown reason, cyanosis, they have altered mental status, they're agitated, their anxiety, cardiac arrhythmias, bradycardia or tachycardia, hypertension. So basically, the first initial measure that you do once the patient arrives to the ER with any type of symptom that is related to hypoxia or ischemia, you provide oxygenation. Methods of oxygen delivery basically is nasal cannula is the most common. Venturi mask, which gives you a precise amount of oxygenation, and this is very important for patients that tend to retain CO2. So Venturi mask is very commonly used for patients that have COPD. 100% non-rebreather mask, and as well as non-invasive ventilatory support, which is the BiPAP, and mechanical ventilation. In case you don't remember the amount of oxygen that is delivered per liter of nasal cannula, remember that you breathe in room air, which is basically 21%. And after that, you basically per liter, you increase by 2. So 21% room air. Then you go 2 liters is 24 to 28. So if you basically go 21, 1 liter is 24, 2 liters is 28, 3 liters is 30, 4 liters is 32, and so on. Remember that after you pass 6 liters, which normally in hospitals they go up to 5, which is 40% to 50%, you should be requiring a higher degree of oxygen delivery. So you either jump into a venti mask or partial rebreather, which is 80 to 90%, or non-rebreather, which is 100%. For Venturi mask, they go basically by color. The blue is 24%, the yellow is 28%, the white is 31%, the green is 35%, and the pink is 40%. This is if you basically would like to recognize it at a glance instead of looking at the number. Remember that if you're concerned about CO2 retention, Venti mask is the best. But if you want to use nasal cannula, remember that these patients require low flow oxygenation, so basically 1 to 2 liters. Then you have the partial rebreather, which is basically up to 80%, and then or 90%, and then non-rebreather, which is 100%. And the main concern is that could lead to oxygen toxicity, and we'll review the signs and symptoms of that as well. Mechanical ventilation is basically provided via an endotracheal tube. Is a common support used for critically ill patients, and it's the definitive intervention to ensure adequate oxygenation and ventilation. It does allow the administration of 100% of oxygenation. Each mechanical ventilation respiratory cycle is divided by inspiration and expiration, as you know. The amount of gas delivered during inspiration is limited by volume, pressure, and flow. Cycling is the changeover from the end of inspiration to the second phase of expiration. It could occur in response to elapsed time, deliver volume, or decrease in flow. Expiration begins when the gas flow coming from the ventilator is stopped and the exhalation circuit is open to allow gas to escape from the lung. Expiration continues until the next inspiration begins. Triggering. Triggering is the change over from expiration to inspiration. All mechanical ventilators require some signals from the patient, except when the patient does not interact with the ventilator, such as in assist control, pressure control. When the patient initiates the breath, it is called an assisted breath, and a triggering signal results when the patient inspiratory effort produces a drop in air pressure. In the absence of patient interaction with the ventilator, breaths are delivered based on elapsed time. This is called an unassisted or mandatory breath. In mechanical ventilation, there are controlled breathing patterns for patients who are unable to maintain adequate ventilation. It is basically an expected temporary support that buys time for correcting the primary underlying pathology process. Indications for mechanical ventilation are basically mechanical failure, ventilatory failure, oxygenation failure, for general anesthesia, post-cardiac arrest, and remember all those patients that cannot maintain airway properly. There are two categories of ventilator, negative pressure ventilators that are not in use anymore, such as the iron lung and the Curis ventilator, and the positive pressure ventilators, which are now in practice used. There are two categories, basically volume cycle or volume preset, and pressure cycle or pressure preset. The volume cycle breath, often called volume breath, ensures the delivery of a preset tidal volume. And remember, I'm emphasizing on the preset tidal volume. On some ventilators, the setting of peak inspiratory flow rate and the choice of inspiratory flow waveform determines the length of inspiration. As lung resistance and compliance change, some ventilators adjust inspiratory flow to maintain not only the preset tidal volume but also the preset inspiratory time. With volume cycle breath, worsening airway resistance or lung change wall compliance results in an increase in peak inspiratory pressure with continued delivery of the set tidal volume. So in other words, in volume cycle, It terminates inspiration after delivering of a preset volume of gas or tidal volume. The delivery is regardless of required pressure, and the volume remains the same, so is not taking into account the patient's effort. In pressure cycle, often called time cycle, applies to a constant pressure for a preset time. The constant pressure throughout inspiration produces a square pressure over time waveform during inspiration and a decelerating inspiratory flow waveform as the pressure gradients fall between the ventilator and the patient. With this type of breath, changes in airway resistance or lung chest wall compliance will alter the tidal volume. Worsening of airway resistance or lung compliance results in a decreased tidal volume. This disadvantage of pressure control breath may be overcome by delivering pressure-regulated breath, in which the ventilator adjusts the pressure up and down in response to a fall or rise of the tidal volume. So in other words, in pressure cycle, the termination of inspiration is done when a preset pressure is reached. It has varying degrees of resistance that would interfere with gas flow. It is best used when you have already exhausted your parameters in volume cycle, and also for patients that are overdose or basically when you are already maximum support 100% FiO2 and a high PEEP. It is not good for postoperative or severe respiratory infection, although sometimes when the patients go into refractory hypoxemia, such as ARDS, due to sepsis, is also used, but is not preferred because of the amount of volotrauma and pressure trauma, such as pneumothorax, that this cycle could produce. Volume preset modes include a control mode ventilation, such as CMV, intermittent mandatory ventilation, which is IMV or SIMV, and assist control, which is the most commonly used. Volume variable is the pressure support ventilation, the pressure control ventilation, the pressure regulated volume control ventilation, which is not very common in use, and the positive airway pressure. You have the PEEP, and you have the continuous positive airway pressure, which is the CPAP. So now we'll review the different modes of ventilation. Control mandatory ventilation basically allows total control of the patient's rate and tidal volume. It is used for patients needing short-term ventilation when no inspiratory effort is desired. For example, patients that have multiple injuries, neurological injury, drug overdose. Assist control, which is the most commonly used, and that's the one that I want you to put emphasis on, is also called CMV. It is typically delivery with either volume cycle or time cycle, which is pressure cycle. A preset tidal volume or a preset pressure and inspiratory time is delivered at a preset minimum rate. The patient receives a minimum number of ventilatory breath or backup rate synchronized to spontaneous effort, and the number of breath can be increased beyond the preset rate with additional inspiratory efforts. This mode of ventilation is commonly used when mechanical ventilation is initiated in patients with acute respiratory failure or any other etiology. So basically, it's the most common initial mode of ventilation. With proper use of assist control, the work or breathing may be significantly decreased. However, if the ventilator and the patients are not in synchrony, or if the ventilator inspiratory flow rates are not matched with the patient's demand, this mode of ventilator support may lead to significant amount of patient's work. So in other words, allows the patient to initiate inspiration and control the frequency. Patient-initiated breath are delivered at a preset tidal volume and a preset rate. Can allow inappropriately high minute ventilation and increased work of breathing, even though the main purpose of this mode is to decrease the work of breathing. IMV or SIMV, which are very much similar, is called basically synchronized intermittent mandatory ventilation, or just intermittent mandatory ventilation. It delivers either volume cycle or time cycle at a preset mandatory rate. Volume cycle is the most commonly used. When the number of inspiratory efforts by the patient exceeds the preset mandatory rate, the additional patient effort acts as fresh gas from spontaneous breathing. Typically, SIMV is initiated at a set to deliver full ventilatory support, and support is then decreased as the patient tolerates spontaneous breathing. So basically, when you put this mode of ventilation, you have to also put pressure support on it. Synchronization basically allows for enhanced patient ventilation interaction by delivering a preset breath in conjunction with the patient's inspiratory effort. When no effort is sensed by the ventilator will deliver a preset volume and a preset rate. Synchronized intermittent mandatory ventilation is almost always combined, as I told you, with the pressure support to augment the spontaneous breath. At a minimum, the pressure support should be set between 5 to 8. But we have increased in practice. In clinical practice, we could give pressure support of 15, pressure support of 20, and then coming down to pressure support of 12, pressure support of 10. We have never gone as low as 8 to 5. When the patient is already on pressure support of 10, we could start a CPAP trial. So basically, IMV and SIMV are very similar. A patient receives a baseline minute volume. The patient breathes spontaneously. So it could be fast, it could be slow, and it has a variable tidal volume. SIMV is also explained here. The key advantages of this is that patients' respiratory efforts are utilized. Is a mode of weaning. So if the patient starts initially in assist control and you would like to wean the patient off, you could either recruit intercostal muscles and diaphragms to make the patient stronger and tolerate CPAP better with SIMV, or just go straight to CPAP. This mode also decreases intrathoracic pressure. So if you are trying to wean a patient that just underwent CABG, you could go straight to CPAP, but you could also go to SIMV because it does increase venous return, it increases cardiac filling. IMV versus assist control ventilation. In patients who are breathing rapidly during assist control and have evidence of overventilation, it could mean that the patient is ready for weaning. So don't sedate the patient. If the patient is ready for weaning and extubation, you could put the patient on IMV or SIMV. In patients with evidence of respiratory muscle weakness, as I said, you have a patient with Guillain-Barré, you have a patient with myasthenia gravis, or a patient that has been ventilated and sedated for a long time, that you are expecting muscle weakness or sedation or due to acuity of etiology, muscle weakness itself, you could start with SIMV and then go to CPAP. But if the patient continues failing SIMV, the best mode for this type of population is assist control. Pressure support ventilation provides a preset level of inspiratory pressure and assists with each spontaneous breathing. This inspiratory assist is selected to overcome the increased work of breathing as well, imposed by any disease process. The set amount of pressure support that is applied augments each patient breath. All breath or flow cycle with pressure support, the patient controls its respiratory rate and exerts strong influence on inspiration, expiration, flow rate, and tidal volume. In addition, the delivered tidal volume is influenced by pulmonary compliance and resistance. Pressure support may also be coupled with SIMV, as I said, primarily as a means to diminish work of breathing. The amount of pressure support set during mechanical ventilation is titrated accordingly to the tidal volume. And I will explain in class how to choose your best pressure support. Normally, the tidal volume is set between 6 to 10 milliliters per kilogram, depending on the patient's need. And then you could start slowing down pressure support according to the patient's breathing rate. You have to always put appropriate apnea alarms and a backup ventilation setting in case the patient does not have a spontaneous breathing. So basically, this set is for this type of mode is for patients that are spontaneously breathing, because the ventilator does not deliver a set volume. Patients determine their own inspiratory flow rate and time, and indications are either an adjunct with SIMV to reduce the work of breathing, or patients that are in long-term mechanical ventilation. Patients that have cerebral palsy, patients that are spinal cord injury that you cannot extubate, you could keep them in SIMV with pressure support. And remember, it's used for weaning mode. It's not used by itself. Pressure support is a factor that is added to either CPAP or SIMV or IMV. Advantages, as I said, reduces the work of breathing. Disadvantages for that is It's dangerous if the patient's respiratory rate slows or stops. That's the reason why you have to set appropriate apnea alarms. And it can be used with PEEP or CPAP, but increases the risk of vital trauma and decreases cardiac output in some population. Pressure control is completely controlled by the ventilator. This is when the patients are really, really sick, critically ill, that you have exhausted all the parameters for assist control. No participation by the patient whatsoever, so this patient must be highly sedated with a Ramsey greater than 3 and sometimes paralyzed with Nimbics. The inspiratory flow rate decreases exponentially during lung inflation, reducing the peak airway pressure and improving gas exchange. Disadvantage for this pressure control is basically based on mechanical properties of the lung. Patients could have volotrauma and barotrauma. PEEP basically is the preset positive airway pressure. It's the same physiological PEEP that you have inside the alveoli that avoids lung collapse and atelectasis. Increases oxygenation, increases the diffuse amount of oxygen to the tissue, maximizes pulmonary compliance, and minimizes shunting. Indication is basically for recruitment. You always start with a PEEP of 5 unless the patient have neurological problems. If you receive a patient with an altered mental status with unknown reason, or patient is unconscious for unknown reason, and CT scan of the brain or MRI of the brain still pending, you do not like to you have to avoid starting PEEP, because remember, PEEP increases intracranial pressure, and also PEEP reduces venous return and preload. So the higher the PEEP, the lower the blood pressure. Advantages of PEEP: improves oxygenation, decreases work of breathing, keeps the airway from collapsing. Disadvantage of that is that the higher you go in PEEP, the higher the risk of vital trauma. It could increase dead space and increases intracranial pressure, so you have to remember that for patients that have neurological damage. Do not start PEEP until the neurologist tell you otherwise. In patients with increased ICP, you must assure CO2 elimination first. They're contraindicated for hypovolemia. Remember, in hypovolemia or any type of low cardiac output or any type of disease process such as pulmonary emboli, that you have right ventricular failure that impedes preload, in this type of population, PEEP will reduce even more the venous return and preload, therefore produces more a profound hypotension. COPD itself is basically because COPD has an emphysema component, so you have to be very careful as how high you have to go on. You will go on the PEEP, because remember, increases pressure at the level of expiration in the alveoli, and increases the risk of vital trauma even more if the patients already have severe or advanced COPD with bulla. They could provoke a rupture of a bulla and pneumothorax. It doesn't mean that you won't use it. If you must use it, you just have to be careful how high you go. If the patient is severely sick and requires PEEP of 12, PEEP of 15, you have to be able to achieve proper oxygenation status. But the risk for vital trauma increases as the higher you go. CPAP is basically constant positive pressure that is applied throughout the respiratory cycle. This is a weaning mode as well, and this is basically the last weaning mode before extubation. Advantages is that provides the physiological security of the ventilator being, um, meaning that it's a weaning mode, but as well that if patients tolerate SIMV and they have signs of oxygen toxicity, you're already on the low minimum setting of SIMV, and the patient's FiO2, I'm sorry, PO2 is 130 something or 200, you could put this patient on CPAP. Patients may sense resistance because they're completely awake. They're aware that they're intubated, so it's very, very hard to breathe through that tiny tube. It doesn't matter which size you choose. So patients describe that they feel like if they're under the sea, breathing through straw. So that's how difficult it is. Before we go to the care of the ventilator patient, what are the guidelines to initiate mechanical ventilation? Choose the ventilator mode with which you're most familiar with first. So if you're more familiar with assist control, start with assist control. If it's very difficult for you to manage pressure control, don't start there. I mean, anyways, the first initial mode is assist control. You never start in pressure control unless you have exhausted already your AC parameters. The initial FiO2 should be 100% on all the patients. So unless you know the patient, if you know that this patient is a COPD chronic patient and you had the patient already on the floor and he was oxygenating properly on 40%, it's at your discretion to start at 40% mechanical ventilation if the patient gets in distress. But the rule is every patient that requires mechanical ventilation, the FiO2 should be 100% to start, and then you adjust based on ABG. The initial tidal volume is from 6 to 10 milliliters per kilogram in patients that have normal lung compliance. In patients with poor compliance, such as ARDS, the target tidal volume is 6 mLs per kilogram. And that is recommended to avoid overdistension and to maintain inspiratory plateau pressure less than 30 to avoid barotrauma and volutrauma. For respiratory rate and minute ventilation, choose the respiratory rate and minute ventilation appropriate for that particular clinical requirement. For PEEP, basically you have to achieve plateau pressure and PEEP. You start with a 5 and you increase slowly as tolerated or required by the clinical condition if it's necessary. PEEP greater than 15 are rarely necessary unless the patients have ARDS. Set the trigger sensitivity, set the apnea alarms. As a nurse and nurse practitioner, you have to always observe the type, the size, and the position of the tube at the bedside. If you remember that it was placed at 22, it must continue at 22 unless it's dislodged. You could also see it in the chest x-ray, and I'll help you in class how to actually look at the proper insertion of the ET tube. Pulmonary assessment. Remember that you don't provide oral care, but you must order oral care, PRN, for this patient. You know that the tube, the actual tape is changed depending on the institution, Q24 to 72 hours. Monitor for complications, and try weaning and extubation every day if it's appropriate. Remember your complications: disconnection, ventilator-associated pneumonia, your acid-base imbalance that the patients could have being ventilator, oxygen toxicity. Don't keep the patient on a high FiO2 if it's not necessary. Pneumothoraxes, curling ulcers and GA bleeds, battle trauma, and remember your PEEP decreases cardiac output. If you want to change oxygen parameters, so if the patient is hypoxemic and you want to increase oxygenation, the two parameters that increases oxygenation in the ventilator are FiO2 and PEEP. So if the patient is hypoxemic, you could increase FiO2 or you could increase PEEP. If you want to change CO2, if the CO2 is elevated or decreased in the ABG, the only parameters that respond to that is respiratory rate and tidal volume. So we'll do some exercises in class to be able to adjust that. You must also be aware of your ventilator alarms. What does high pressure alarm means? It means blocking. It means that the tube is kinked, that the patient has secretions, or also that the lung compliance is altered due to ARDS. Low pressure alarm is not enough pressure, so the patient is basically extubated themselves or the tube is dislodged. High minute volume alarm is that the respiratory time and the tidal volume is increased, so the patient is hyperventilating. So either the patient has pain or the patient is anxious or is too awake. And if the patient is not in a weaning mode or close to extubation, you must sedate the patient again. Then you have FiO2 alarms that usually is due to leaving the patient at 100% after hyperoxygenation before suction. Leaving the patient in high oxygen is not appropriate because patients could go into oxygen toxicity. Oxygen itself could induce hypoventilation, which that increases the CO2, patients become hypercapnic, and also could produce absorptive atelectasis. So decreases alveolar volume, produces mucus plugging and airway obstruction. Signs of oxygen toxicity. Of course, the patient is not going to be able to tell you this if they are in mechanical ventilation, but if they are in 5 liters of oxygen and is not adequate, patients could have pain of ischemia, cough, dyspnea, anxiety, optopulmonary infiltrates, and edema. So you could review these symptoms as well. Potentiators of oxygen toxicity, meaning that if the patient is a COPD and they tend to be CO2 retainers, this condition itself could potentiate oxygen toxicity. Patients that are in the ICU that are in vasopressor support, patients with insulin drip, patients with thyroid disorders, patients on amphetamine, etc. Inhibitors, on the contrary, could be patients with hypothyroidism, hypothermia, adrenergic blockers, anesthesia, etc. Weaning from the ventilator. It's very important to try weaning every day. You have to be able to measure vital capacity. The vital capacity must be at least 10 to 15 milliliters per kilogram to decide to wean. Tidal volume greater than 500 or 5 mLs per kilo. Resting volume more than 10 liters per minute. Adequate ABG on an FiO2 less than 40%. Patient must have stable vital signs. They should have a strong cough, a strong gag, being able to raise the head away from the bed, absence of dyspnea, absence of pain, diaphoresis, restlessness, or the use of accessory muscles. So the patient must be hemodynamically stable, preferable of vasopressor support, and they must be within these parameters. Extubation procedures basically explain the patient the procedure itself. The respiratory therapist must be at the bedside. Suction the airway, and this basically is done by the respiratory therapist, but you should know the process itself. Place a towel on the patient's chest because mucus are coming out with the extubation. Assure that the new oxygen order and setup is already at the bedside. Deflate the cough, explain the whole procedure to the patient, and of course apply the oxygen that was ordered. Normally, even though the patient is oxygenating properly, the way I order it is, for example, if the patient was already at 35% FiO2 on the mechanical ventilation, I would put Ventimask 35%, even though the patient's PO2 is 100 and something or 200 and something. I always start at the same FiO2 and wean as tolerated. And of course, as soon as you extubate, monitor the patient for distress. Listen to the neck for stridor with the bell. Tell the patient to speak to be able to monitor laryngeal damage or vocal cord damage, and also patient's coughing reflex and anxiety level. Thank you very much for allowing me to explain the modes of mechanical ventilation. So basically, in class, we'll go over case studies and adjust mechanical ventilatory parameters.